I realize we're running short on time, but are there any questions? Yes.
Hi, Ed Sussman with MedPage Today. Dr. Jeremy, the New York City results seem very good for the U.S. What's the comparison between, what's the situation throughout the United States compared to what New York has found?
I think Lucia probably can answer that.
We have a bit of an advantage over the national data. We're clearly not doing as well as they do in San Francisco, and you may have heard that presentation yesterday. But we are right at the same level as the national undiagnosed rate. So they are projecting, CDC's projecting 14% or estimating 14%, and we are at that right now by the results of our last serosurvey. I think we have seen a very steep rise in viral suppression that is coterminous with changes in practice and possibly also with changes in guidelines. We have not seen as steep a rise in linkage to care. That has been a bit more modest. And other jurisdictions like San Francisco also have a good surveillance system and are also following this. But we have the advantage of having longer term laboratory reporting data, and many of the big states with the big epidemic have just begun their laboratory reporting somewhat later than we had.
Could you say anything about the effect of laws on your results, laws that have been in effect in New York City and New York State, in terms of requirements to report laboratory results and linkage to care?
So laboratory reporting has been in effect in New York State since 2000, and it was expanded to include all values, including high CD4s and undetectable viral loads, both of which are not HIV related, but we investigate all possibilities. And so the law made it possible for us to create a surveillance system like this. And then in 2010, there was a New York State law that required proactive offering of voluntary testing to all comers to any medical provider, emergency room, inpatient unit, private doc, whatever it was, and also proactive linkage to care. So I think these things, whether they were the main drivers of the outcomes or not, I certainly can't say, but they are coterminous with that, as is the rise in viral suppression among people with higher CD4 counts after the 2010 federal guidelines, when the panel started thinking seriously about the over 500 people and about opening up treatment at all levels.
Yes.
Dr. Smith, I'm Donald McNeil from the New York Times. Could you tell us a little bit more about who the attackers were in the rape suit? Were they domestic partners? Were they customers? Were they police officers? Were they gay bashers? Who was doing most of the attacks?
Well, we, as I mentioned previously, we have no event level data for each of these events themselves. Overall, the categories that we were able to request of the features of reported last assailants, so not all assailants, are limited to only 150 events in their own right. So we don't really have robust enough data to draw any very firm conclusions about individual occupational groups, such as you mentioned. Overall, though, we were quite struck by, both for female sex workers and MSM populations, that the vast majority of individuals reported to be assailants were clearly known to the individual before the event took place. So more so for female sex workers who reported
known in what way? I mean, known as in lived in the same household, or known as in had as a customer
I'll come
before?
to that. So overall, 79% for female sex workers compared to 62% for MSM overall, constituting neighbours, local residents, regular sexual partners, and family members. And we were we were surprised that, having thought that, particularly for the female sex worker population, that we might be seeing violence associated with new sexual partners and new sex clients, that actually they represented a very small fraction of the assailant reports that we had.
The other question I had was, how do you know what you don't know?
You don't.
You know, you're estimating that 14% are undiagnosed. How do you know that? Or what's that based on?
We conduct serosurveillance in hospital emergency rooms, and our last estimate is 14% undiagnosed. Is it representative? Is it generalizable? Not necessarily. It's what we're doing is the best we can with what we've got. We are updating that estimate with another. We're in an emergency room right now at a very large hospital that draws blood on 80% of everybody that comes through the emergency room. That will be a better quality serosurvey than the one that we did before. And by the way, these are all blinded, so the identifiers are taken off. We use chemistries and hematologies that have already been used for clinical testing, so we're basically using leftover blood. You're absolutely right. It's a great question.
I think Donald Rumsfeld could have answered that. Never mind. Yes.
Dr. Momo, do you have any explanation for why the men's viral loads were so much higher? Are they being diagnosed later in the infection because women are often infected younger, or what's going on? I mean, why something physical?
Okay, this is something that in the US in the 80s, there was already studies that showed that men, independently of their CD4 levels, they had a higher viral load. At this time, the question, it was not about transmission, because most of the transmission in the US was not driven by heterosexual thing, and the question was not so much about prevention. The question that they were trying to answer at the time was progressions toward toward AIDS, where men was advancing faster, and they did not find any thing. What we looked is that CD4, men have lower CD4 in the population. They are at more advanced stage of the disease when they are not on treatment. But this does not explain it, because even in the model, when we take that in account, the CD4, it does not explain. So we found the same thing with other subtype of HIV in Africa that was already found. And for us, as the epidemic is heterosexual, it has other, because what is driving the epidemic in Africa is heterosexual transmission. So it has completely other, we know that prevalence is higher, incidence is much higher among women. We try to understand why, and I mean, it's reinforcing policies that we need to find men and treat them.
But you were taking into account the time of diagnosis, I mean, the time from infection to the time of diagnosis?
Most of these people are undiagnosed people. They are in the population. We go to their house, and the day we diagnose them, we take their viral load. It's a different way of doing that.
But you adjusted it for CD4 count, right?
Yeah, of course.
So at the same CD4 count, men have higher viral loads than women?
No, because there is so many people who are infected with HIV. We are not talking about 0.2, 0.1% or 0.4. It's 17 to 25%. So every 3 or 4 or 5 houses you go, you find. So you randomly select thousands of households. You have people walk, and when they are positive, they take blood, and the blood is transferred very quickly, extracted, and transferred to a reference laboratory.
Okay, but you have no idea how long they'd been infected.
No,
This is the
of
first
course
time they're being diagnosed. And the ages are the same?
Sorry?
And the ages are the same for the men and the women?
No. I mean, age was not a factor of higher viral load, but usually men are infected slightly later than women. There is a 10 years differences in Africa usually.
Okay, thanks very much.